just give my presentation, and I hope that it's for you, it's extra information for the future of thrombus removal. I have no disclosures. And well, what I'd like to tell you first is that we did a trial, the CAVA trial, in which we had patients with iliofemoral DVT, not femoral DVT, and we randomized them between conservative treatment and additional ultrasound accelerated catheter-directed thrombolysis. And the primary outcome was PTS after 1 year. And unfortunately, as all the other two studies, the CAVAN study and the TREC trial, we didn't show any significant difference. And if you look at the three trials, CAVAN had just a significant difference of less PTS after 2 years. The TREC trial was not significant different, and our CAVA trial was also not significant different. So the conclusion could be that aggressive endovascular treatment for iliofemoral DVT does not prevent PTS. But if you look further in those studies, then there are some things to look for. First of all, we looked at the group of patients who were successfully treated in the intervention group and what happened to them. And we said when it's successful when the PTC is restored for more than 90% if in the tract that was occluded. And if you take that as a successful thrombolysis, then we looked at our data. From the patient, the 77 who got additional ultrasound accelerated catheter-directed thrombolysis, unfortunately, only 53% was successful, and the 47% was unsuccessful. This is very disappointing, but it influences the outcome, of course, significantly. If you look at those two groups, we saw that, let's say, the distribution of thrombosis in both groups, successful and non-successful, was equally distributed, no significant difference. The only difference we found before in the group which was successful versus unsuccessful was the duration of symptoms at inclusion. And that's logical because the older the thrombus, the less chance you have that thrombolysis will work. If then you look at the complication rate for successful versus unsuccessful, there was no significant difference. Then we looked at the outcome after 12 months, and then we see that the successful group was significantly lower Villalta scores. So there was really less PTS in the successful group. If we look at the definition of the Villalta with mild, moderate, and severe, then we see that if you have a moderate to severe PTS after 1 year, that group was significantly less in the successful group. And also at the severity score, we saw that the severity score also improved significantly in the successful group. We also looked at the quality of life data, and then you see that the SF-36, the social health, was significantly better. The role of physical limitations in the, let's say, generic quality of life was significantly better. The SF-36, the pain score, was significantly better. The EQ5D, that's also a generic quality of life score, which is important to calculate QALYs if you want to do that, was significantly better. And if you look at the disease-specific quality of life scores, the VANES total and the VANES intrinsic, they also were both significantly better. So in total, we could say the successful group was much better. We also looked at the long-term data, which was not separated between successful and unsuccessful. Then after 39 months, there was a significant improvement in the group with additional thrombolysis. So if we, and we didn't do that analysis yet, but if we would also in this long-term follow-up separate successful versus non-successful, then we probably have a much more significant improvement in quality of life and other outcomes measures for the patients who got a successful thrombolysis. The other thing we did is that all the patients got an MRV before the treatment. We didn't use this in the trial. It was done, and after the trial was finished, we looked at all those MRVs, which is good that Arnoldus published on it, that you can see on an MRV very well that if there's a normal vein, if there's an acute thrombosis, the vein dilates, and we have a very clear, extended, homogenic discoloration showing that there is an acute thrombosis. The subacute thrombosis is due to the inflammation. You see that there's a halo around the vein related to the inflammatory response to the thrombus. If you see that the vein has been shrinking again, then we say this is an old thrombus. And then if it really further shrinks down, then you really have a post-thrombotic changes without thrombosis. And then if that one dilates again because of a fresh thrombus, we will have acute on chronic. Well, he looked at all those, let's say, qualities of the MRV, and it's very clear that this is a very sustainable observation, and you can use it to select patients for your procedures. We also looked at our data. On the left side, you have the duration of complaints at the start of the trial. We see that there are the acutes, the subacutes, and then a little bit older ones who were included in the trial. And you see that although you think that there is only 7 to 14 days, 33% of those had still an old thrombus. Between 2 and 3 weeks, there was even 58% having a very old thrombus. And the very old ones, well, that was exactly the same. And if you look at the outcome of the MRV, acute, subacute, or old, and you look at your success rate, then your success rate in the acutes is 70%, in the subacute is 64%, and in the old group it's only 16%. And the time for lysis is also very clear that in the acute group you can do it in 1 day, in the subacute group it takes 2 days, and in the old group it takes more than 3 days, and then finally without any success. So we concluded that a low percentage of successfully treated with all available techniques. The Kevin study didn't look at this specific issue for if it was successful or not successful. We did it, and we saw that only 53% was successfully treated. In the ATTRACT trial, there's a subgroup analysis done by Comarota, also only showed a 50% success rate after being treated in the aggressive group. If the thrombus removal is successful, showing the papacy restored more than 90%, it does lower the incidence of moderate and severe PTS. It does has a positive impact on generic quality of life, disease-specific quality of life, the Villalta scores, and the VCSS scores. The success is mainly determined by the thrombus age, detected on the MRV, which does it better than, let's say, the historic information of the patient. And there are technical issues. The material we use is not very positive yet. I think with these techniques on thrombolysis, we need better tools. And of course, the experience. We know that especially from the ATTRACT trial with so many centers involved, you need really an expert center to improve the outcome. So in conclusion, yes, thrombus removal is very valuable in acute DVT, but we need faster referrals. If the patient is sent in early, then the outcome is very good. And it's very easy for a GP or anybody involved with the treatment of DVT patients. If a patient has a DVT and his complete leg is swollen up to the groin, then the chance that he has a treatable occlusion in the iliac tract is very high. So those patients should be referred fast to a dedicated center. In the dedicated center, you need an MRV because then you can detect when it's an old thrombus and you don't do the treatment. Better tools. We need mechanical thrombectomy devices because then we don't need thrombolysis. The patient doesn't have to go to the ICU. So that will reduce the cost. You don't have thrombolysis, so you don't have those bleeding complications. And what's very important, if you do it mechanically, you can increase the indications because patients, postoperative patients with a iliofemoral DVT and cancer patients with iliofemoral cannot be treated with thrombolysis, but they could be treated with a mechanical thrombectomy device. And finally, there should be better scoring systems. The Velalta is not good enough. It doesn't include venous claudication, which is very important. And it adjusted, the VCSS is necessary and a better quality of life tool to really score the important information to see when it was successful and when not. So yes, there is a future for thrombus removal in acute DVT, and the lessons learned so far, which we use now in our daily practice, for the better patient selection, we think an MRV is mandatory. You need to do that up front. There are two things you can see for if it's acute, subacute, or old, and you can also detect, let's say, stenosis in the common iliac with a May-Turner, for instance, that you know up front that will be a part after successful thrombolysis that you need to stent, and only in dedicated centers. Mechanical thrombectomy first, that's what we do now, but it's still not perfect because it doesn't drill, it doesn't take all the thrombus out, it leaves thrombus behind, so we do first thrombectomy mechanically, and then we do thrombolysis to get rid of the residual thrombus after it, and it reduces lysis time and also the amount of medication. The VCSS, VCOL-SIM, EQ5D, venous claudication score, we use this all to evaluate the procedures, and we left the Velalta score. So finally, I just want to use this opportunity to invite you to the European College of Thrombology course in Amsterdam, Oegstgeest, 18 to 20 May 2023, in this very special venue in which you go through the body and you can go through the guts, through the vessels, through the heart, to the brain, in this kind of museum, which has a very nice venue to also have a nice meeting with all the things, all the issues covered in the sessions done. Thank you very much, and sorry for not attending.